You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 25th, 2025. We are doing our orientation series, and today's topic is urticaria and angioedema. This is presented by Dr. Aarti Pandya. She is an associate professor of pediatrics and is the medical director of Food Allergy Center at Children's Mercy Hospital in Kansas City.
Everybody, welcome to our COLA orientation series. I'm Aarti Pandya, Medical Director of our Food Allergy Center, Assistant Professor of Pediatrics here at Children's Mercy, as well as the University of Missouri, Kansas City. Today, we are talking about urticaria and angioedema. Relevant disclosures to this topic include being a speaker for Sanofi or Regeneron, having a Thermo Fisher grant, and writer for the practice parameter revisions for immunotherapy. Our objectives today, pretty simple. We're going to discuss and diagnose the urticaria, provide a treatment plan for that disease, as well as discuss etiologies for angioedema. Let's start first with the prevalence of urticaria. In the U.S. population, 15 to 23% of individuals are going to experience urticaria, and 40% of individuals with urticaria will also experience angioedema. But this is probably lowballing those statistics because this is all self-reported, and we know that the studies don't always capture every single incident of times that patients experience urticaria. So it's postulated that the statistic is going to be higher in terms of total prevalence of experiencing urticaria once in your lifetime. And you can see the breakdown here of individuals who experience urticaria, amongst that urticaria and angioedema compared to just angioedema alone. Acute urticaria occurs in up to 20% of the population. It may be associated with a drug or food allergy or with infections. Generally, it's self-limited. Prevalence for chronic urticaria occurs in up to 1% of the population in most cases. Lesions are spontaneous. There's without an identifiable external trigger. We're going to circle back to that in a little bit. One theory in a subset of patients is that there's autoimmune predisposition. And amongst approximately 20% of patients with chronic urticaria can have a reproducible trigger. Again, the statistic for that could be a little bit higher, like closer to 30 to 40%. So this is a phenotype called chronic inducible urticaria. Again, this is going to be discussed a little bit later in our talk as well. Let's start first with the definitions. So the definition of urticaria is where we have, and it's urticaria, the correct pronunciation for that, we have pruritic erythematous papules or plaques with superficial swelling of the dermis. So that's our definition of urticaria. With angioedema, it's going to be a subcutaneous or submucosal swelling that results from extravasation of fluid in the interstitial tissues. Again, highlighting that 40% of individuals who experience urticaria can have associated angioedema. Angioedema can affect various parts of the body. It is associated with loose connective tissue being affected. So this can include the face, lips, mouth, throat, larynx, uvula, extremities, and genitalia. In terms of definitions for timing, acute urticaria is going to last for 6 weeks or shorter, and chronic urticaria is going to be longer than 6 weeks. Pathogenesis for acute and urticaria and angioedema. When we talk about angioedema from mast cells, this is primarily going to be with mast cell degranulation. Here we can also have perivascular leukocyte infiltrate composed of lymphocytes, eosinophils, neutrophils, and basophils. Again, those are kind of later phase cells that get recruited at the site once your initial inflammation has been onset from mast cell mediators. And then angioedema can be either mast cell mediated or bradykinin mediated. Again, something we'll highlight on a little bit later. Chronic urticaria, it can be segmented into two major phenotypes, inducible or spontaneous. 20 to 30% is inducible. So this means that there is some type of physical trigger that can onset your disease or trigger the disease. In spontaneous urticaria, there is an absence of that. So we do not have that onset. 20 to 30% of chronic urticaria is inducible. And in cases of cold urticaria, our patients are particularly at risk for systemic reactions. So we do discuss needing to carry an epinephrine autoinjector, having special precautions in certain environments where that predisposition is higher. For instance, procedures, operating theater, going swimming, lunging into a lake, all of those are predispositions for having an episode of anaphylaxis in cold urticaria. If cold urticaria is present, we do need to also ensure that a history for autoinflammatory syndromes is considered and taken at the time, because many of those have a major clinical manifestation of cold urticaria. In terms of our inducible triggers, you can see multiple that are listed here. I'll briefly go through those. Again, we're talking about chronic urticaria with inducible triggers. So dermatographism is where we have stroking, scratching of the skin, or pressure that can induce the episodes of urticaria. So here, most commonly what we think of is taking like a tongue blade and drawing an X or a couple of X's on the back and watching to see if you develop urticaria in that spot, or urticaria in the exact area that this stroking has occurred with the tongue blade. Delayed pressure urticaria is where you have to apply pressure for at least 30 minutes to 12 hours before onset of that. So there's some weighted tests that we can do with the shoulder swing and shoulder sling, as well as a weight. Cholinergic urticaria is one of our more common causes of inducible urticaria. Here, anything that causes an elevation of body temperature. This can include hot showers, this can include exercise, strong emotions, spicy foods. So oftentimes these patients will come in and say, can you test me for spice? And in reality, they're not having an IgE-mediated reaction to pepper. They're having an irritant issue, or not, they're having a physically inducible issue that's coming from the nature of spice of the food itself. And then there is inducible tests for this where you can essentially do exercise and watch for clinical symptoms that occur. Cold urticaria is when you can have exposure to cold air, cold objects, or cold liquids. So one common question we ask in these patients are, well, how do you do with ice cold beverages? Do you get a sensation of swelling in your throat? Do you get, urticaria inside the mouth when you're drinking those beverages? That can certainly be a clinical manifestation of that. Otherwise, of course, onset of urticaria and angioedema with exposure to cold, touching the snow, being outside in a particularly cold day can also induce urticaria as well. Heat contact urticaria occurs with contact with a warm object with the skin. Aquagenic urticaria is when we have skin contact with water at any temperature. So it can be difficult to delineate that with cholinergic urticaria. Note that aquagenic is not dependent on the water temperature. So that's an important feature to delineate those two. Same thing with solar urticaria. Oftentimes when that's a clinical question, that can be confounded with cholinergic urticaria. Solar urticaria is exposure to sunlight, again, at any temperature. So it doesn't really matter if it's 65 degrees or 50 degrees versus 90 degrees outside. But essentially, this is exposure to UVA, UVB light that can trigger it. And then lastly, vibratory urticaria. So how do we recognize this happening, or what's a common situation in which this can happen? Actually, when you're driving and your wheel vibrates, you can break out in urticaria on your arms and further by nature of the vehicle vibrating, essentially. Otherwise, lawn mowing, riding a bike, any vibrating machinery can do that. And on the vortex platform of the skin, you can place an object that vibrates for 10 minutes and observe for clinical symptoms. CU mechanisms. So with regards to this particular topic, we are going to see in a further slide here, there's a postulation of different mechanisms that can, contribute to chronic urticaria. One particular one that we think of is the development of an IgG antibody to our Fc epsilon receptor, R1 receptor, and this can trigger kind of an autoimmune phenomenon. But in any case, what's essentially happening is something at the level of mast cells and basophils is causing degranulation. So whether that be an autoimmune mechanism or otherwise, we do know that that's largely what is, contributing to the clinical symptoms that you're experiencing. In terms of the natural history of chronic urticaria is a self-limited disorder. Average duration of the disease is about 2 to 5 years. In patients in whom no trigger is identified or underlying disorder, the rates of spontaneous remission at 1 year is reported to be about 30 to 50%. However, symptoms persist beyond 5 years in 1/5 of patients. I think the majority of you who have seen patients with chronic urticaria with me will know that I educate that right off the top of the bat, because the one thing that can commonly happen is these patients keep coming back and say, you didn't do anything for me. So it's not that I didn't do anything for you, it's that this is the nature of your disease. That doesn't mean I can't, and that doesn't mean we shouldn't optimally symptomatically manage these patients. We should still meet them at their treatment goals. But the reality is they're not doing anything external to trigger this beyond maybe some unavoidable physical triggers that may happen just by sheer existence, that can happen. So that's a very important point to educate your patients on, so they have an expectation and understanding of their disease. Okay, sorry about the smaller words here. Hopefully on the recording it's a little bit clearer to see, but in terms of identifiable causes of urticaria, when there is an identifiable trigger, it's going to fall within this particular chart. If you are not finding something in this particular chart, then the likelihood of finding, an identifiable cause drops. The majority of cases of acute urticaria are actually idiopathic. And I think a couple of us have talked about this. When there is an identifiable cause, including respiratory infection, let's say, we can identify it at the time. We know that that's a trigger for it. But there's a statistic about 80 to 90% of individuals will have an idiopathic acute urticaria episode that's idiosyncratic. It won't reproduce later in life. Doesn't mean that they're at risk for any systemic disease going forward in the future. So you can see with that discussion, infections are at the top, particularly in our pediatric patients. These can include viral, bacterial, parasitic. Medications are going to be another common cause of urticaria, and this can include any and all medications. I do want to highlight here antibiotics, nonsteroidal anti-inflammatories, and opiates fall pretty high on that chart. Foods include our top 9 food allergens, of course. Outside of that, we can still get other food allergens that can contribute to urticaria. So those are all listed here. Contact urticaria, this can include latex, this can include stinging plants, contact allergens as well. Physical stimuli we discussed in detail. Additionally, there are some rare causes here that are some here are even independent of IgE mechanisms, including radiocontrast media, COVID-19 infections, scrobwoid poisoning. And then lastly, again, as Dr. Spring had discussed earlier today, systemic disease consideration, which includes mastocytosis, serum sickness, autoimmune diseases, hereditary alpha-tryptopenia, all of those things fall under systemic diseases. How do we monitor disease in individuals who have chronic urticaria? We obtain what's called a UAS7. UAS7 is a standardized validated test that looks at urticaria activity in the urticaria activity score. You use 2 parameters when you calculate this. You use pruritus in the absence of a rash, and then you use urticaria. When you calculate that based on these numbers here, you'll get a single value, and then you have to multiply it by 7 to get a UAS7 score, because it's urticaria activity score over 7 days. And so this is a very important point for us to remember, because in our patients with chronic urticaria, asking them alone if they've had urticarial lesions and angioedema is not adequate to assess disease control. Pruritus is an important parameter to remember, even in the absence of urticaria. And I think I've talked to a couple of you about that in clinic, but that's an important thing for us to remember, because you may be ultimately suboptimally managing the patient. We may be missing opportunities to escalate therapy to prevent urticaria development with certain triggers as well in those patients. Okay, so this is outlining, going through this entire chart, but I think the quick and easy way to do it is just get it for 1 day, multiply it by 7, and then you have your UAS7 score. So that entails our discussion on mechanism and natural history of, acute chronic urticaria in the mast cell-mediated pathogenesis. Angioedema can also be bradykinin-mediated. So with this, we can, of course, develop subcutaneous submucosal swelling, extravasation of fluid into interstitial tissues. An important thing to remember is this is not gravitational dependent, and it's usually asymmetric and it's non-pitting. And the reason I mention that is because sometimes you'll get a referral that'll say, you're here to evaluate for angioedema, and upon taking a further history, you realize this is not angioedema, this is pitting edema of the lower extremities. So you go down a whole different thing for evaluation for those individuals. But even in our angioedema patients, we don't want to assume that they are just having angioedema. You want to start with edema as, your primary complaint and then work forward from there to ensure that the patient is having angioedema. When the patient is having a bradykinin-mediated angioedema episodes, generally your duration of symptoms is going to start at being 24 hours or longer. I've seen this in patients up to 7 days, especially if there's more severe manifestations that occur. The anatomic sites can include larynx, lip, tongue, uvula, skin, mucosal membranes, bowel wall. So unexplained episodic abdominal distension can be part of bradykinin-mediated angioedema. So, especially in our pediatric population, one of the most common causes of bradykinin-mediated angioedema is hereditary angioedema. Of course, medication-induced bradykinin-mediated angioedema still falls under overall the most common cause, but let's start first with talking about HAE. So HAE is related to a C1 esterase deficiency resulting from a functional deficiency of the protein C1 esterase inhibitor, and this is a broad-spectrum serine protease. This particular enzyme is involved in regulating multiple factors here, including systemic proteases, kallikrein, factor 12A, factor 12F, complement, MBL pathway, intrinsic coagulation pathway, fibrinolytic pathway here. So you can see where exactly the C1 esterase can play a role in all of these individual factors. And so it's a pretty important regulator here of your contact system in general. In terms of types of angioedema, this is a great chart that highlights the major causes we think about when we have a convincing history of a bradykinin-mediated angioedema. One other thing to note, in these patients, you're going to have an absence of urticaria and pruritus. You can have a serpiginous rash that happens, so don't think of total absence of rash, but it's going to be absence of a pruritic rash, namely urticaria that can happen. Just make sure that when you're taking that history, you're also evaluating what medications they're on, because of course medications can suppress pruritus and urticaria. So make sure that you're using your clinical factors when you're taking the history of that. So this is where duration of angioedema is very important to evaluate. Anyways, so knowing that, this is kind of the differential that you think about for bradykinin-mediated angioedema. When we think about hereditary causes, HAE1, HAE2, estrogen-dependent, inherited angioedema are what we think of. And you evaluate this by looking at C1q concentration, C1 esterase concentration, C1 inhibitor function levels, C4 concentration, and then C3 has been listed as well. One thing to note here, C4 has been proposed as just a screening test for this. So it kind of depends on if you want to go further down for these two labs, and then especially even C1q right off the bat, or just start with the C4 level. Those are options that you have. In terms of acquired C1 esterase deficiency, you can have acquired type 1 and type 2. Again, your concentration and function levels of C1 esterase inhibitor are going to vary depending on what type you have. And then lastly, in the most common causes, which are all down here, especially ACE inhibitor-induced angioedema, all of your levels are going to be normal. Other drug-induced bradykinin-mediated angioedema, the levels are going to be normal, as well as idiopathic. So while this lab evaluation occurs, I would say in general, while C3 is on this chart, the majority of allergy practices are going to just do C4 and then proceed with these 3 additional labs for evaluation of acquired and hereditary angioedema. Attacks of bradykinin-mediated angioedema, particularly hereditary angioedema, most commonly involve the extremities, including extremities as well as the abdomen, with each accounting for about 50% of all attacks. Over a lifetime, almost all patients with HAE will experience some type of extremity attack or abdominal attack, and then more than half of patients will experience one laryngeal attack. Some patients experience multiple laryngeal attacks, so it's crucial to have prophylactic therapy in those individuals, as well as measures for when to seek medical attention if they, are having a laryngeal concern for a laryngeal attack. Less frequently, angioedema can involve all these other locations here. Trauma, emotional events, lots of different things can precipitate attacks in these individuals. In terms of the diagnosis in general for everything that we're talking about, bradykinin-mediated angioedema, mast cell-mediated angioedema, urticaria, acute urticaria, chronic urticaria, generally these fall under a clinical diagnosis. Now let me put a couple caveats here. Of course, hereditary angioedema requires lab confirmation. However, if your labs are normal and the clinical history is very consistent with a bradykinin-mediated angioedema, there's a strong role here of proceeding with genetic testing because oftentimes this can be diagnosed purely by genetic testing. So there's no clear diagnostic criteria, although I've mentioned all of this throughout the presentation today. And then last thing, particularly when we're talking about urticaria, whether we're talking about urticaria in acute or chronic fashion, remember that the individual lesions are going to resolve within 24 hours, maximum 48 hours. They don't leave any hyperpigmentation or resolution. Now, 48 is a generous number that has been utilized in some studies. The majority of studies and parameters are going to recommend 24 hours for individual lesions. That can be a hard history to take with patients. So here's some tips that I do. I ask them, because they're like, no, the rash lasted for a week. And I say, okay, totally understood that it lasted for a week. If I were to circle a spot on your arm or leg or wherever the rash occurred, how long would that individual spot take to go away? Sometimes they may say, Doctor, I really don't know. That's fine. Then you can have them either track the lesions to know that they're urticarial in nature, or if the clinical history in general is pointing towards urticaria, you can go based off of that. Then if they say, no, I'm pretty sure, like that lesion that you're seeing on the leg today, I know it started 2 weeks ago, then there's something else going on. It's not just acute or chronic urticaria. So if you have urticarial-like lesions that are lasting for longer than 48 hours and leaving hyperpigmentation bruising upon resolution, particularly if the hyperpigmentation and bruising does not follow a scratch pattern, then there is concern for vasculitis, and we need to go down the route of evaluating for that particular disease. So what I mean by that is oftentimes scratching of the skin can leave bruising, but you'll see it in that particular pattern. You'll see scratched linear marks that occur. But if the bruising is occurring where the entire lesion was present and then resolved, really that's where there is concern that something at the vasculature level is inflamed and irritated, and upon resolution, that's why there's hyperpigmentation there. Okay. So testing for urticaria and mast cell-mediated angioedema. Again, the diagnosis here is mainly clinical. It's based on findings, physical exam, and here's that statistic coming back, but now for a chronic urticaria. So in 80 to 90% of adults and children with chronic urticaria, there's no cause that is identified. Tests that have been proposed and considered can include a CBC with diff, CRP, TSH, thyroid antibodies, tryptase, and CU index. Let's talk about the role of these tests and why we consider those. So if we talk about CBC with diff, CRP, maybe even liver function tests, we're really talking about evaluating for systemic disease beyond chronic urticaria. That's the reason that we're evaluating for that. Things like, what Dr. Spring mentioned earlier, mastocytosis and hereditary angioedema, hereditary alpha tryptosemia. So those are the things that you're evaluating with that, or urticarial vasculitis too. So some people will even grab a C4 level for that. Then beyond that, TSH and thyroid antibodies, so hypothyroidism in particular can present with urticaria. Thyroid antibodies, if they are positive, they have a mechanism where you could have a propensity of autoimmune disease, but unfortunately, treatment of the thyroid disease or presence of a thyroid antibody, treatment for some subclinical issue will not resolve the urticaria. So then it questions the role of that particular test, but that's what's been mentioned in our parameters. And then lastly, tryptase and CU index. A tryptase level is really to evaluate for other systemic diseases because, as you heard from earlier today, hereditary alpha tryptosemia may present just as urticaria, but you take a good history there to make sure that there's not other clinical features going on consistent with that disease. CU index is exactly what I was talking about earlier, the IgG antibody to your Fc epsilon alpha-1 receptor. Now, that particular test, there's been lots of studies looking at the role of that test. Does it look at severity of disease? Does it look at longevity of disease? Does it look at response to treatment, better response to certain treatments versus the other? And the answer to that question is that those studies are inconsistent in all of those parameters. So while it is a test you can do, it may end up being an expensive test that doesn't do much else. But here is the dilemma that every single one of us has faced in a patient who we're seeing for urticaria. They think that a test will get you the answer. They're coming with that expectation. They may have been told that expectation by somebody else. And so we, of course, explain here that the role of allergy testing is limited to none in those individuals, making sure, of course, you do a good history to rule out other things. But if they're really demanding, testing to be performed, this is where you can consider some of these. But of course, you make sure you discuss the risks and benefits with the family, including additional costs without additional diagnostic or management value for those individuals. Atypical features, if they're present and not consistent with your diagnosis, here we would consider doing a skin biopsy. And then, I talked about the chronic urticaria index panel as well. Testing for bradykinin-mediated angioedema, again, a good clinical history, including a medication history. So you'll have further talks on bradykinin-mediated angioedema, but the ACE inhibitor induction of angioedema, I think I have a later slide on this. It may not occur just on the first or second day of doing the ACE inhibitor. So making sure you know a good history of how long they've been taking the medication, getting a C4 level, the C1 esterase inhibitor, antigen level, function, C1q, and then we talked about the role of genetic testing as well. So here. This is an algorithm that we use to evaluate recurrent angioedema. You first evaluate, does the patient have associated urticaria? If so, this is likely mast cell mediated angioedema, and then you go down the route of evaluation and treatment for that. If they don't have any associated urticaria, you take a medication history, particularly for ACE level, and then here's what I was talking about, utilizing C4 as a screening test. And you will see variable practices where just a C4 level is obtained, or you get C4 with C1 inhibitor as well as C1 function level. So you go down that route, and then ultimately, if you're negative here, let's say you're negative. Let's say you're negative to all of those things, and you're also negative on genetic testing, and the clinical history is, I think it's resolving in 48 to 72 hours. Now you're in a little bit of a level of ambiguity. Well, is it truly bradykinin mediated? Is it truly mast cell mediated? And what do I do for this patient knowing all the testing is normal? You can actually do a trial of treatment for mast cell mediated angioedema. Put them on some antihistamines, see if their symptoms completely resolve or are prevented. And if so, then you have some diagnostic value using management as a tool. All right, here's ACE inhibitor-induced angioedema. So I'll start first with some context about this particular disease. I know our practice is largely a pediatric practice. Coming from the internal medicine world, I've seen very severe cases of this. I've seen individuals intubated from this. I've seen cases where the intubation, the tongue protruded like outside of the body from this. So I'm starting with that as a clinical note here to show that ACE inhibitor-induced angioedema can be very severe in terms of its presentation. It can be milder too, but it's certainly something that requires, that we use for evaluation. So here they have a strong predilection for the face, lips, and tongue, exactly like I mentioned, for my particular cases that I've seen. Fatalities have been reported. Bowel or extremity angioedema is not as common in ACE inhibitor, but it has been reported, it has been described. The first episode of angioedema in a patient with ACE inhibitor most frequently occurs within the first month of treatment. That's where I was talking about using that clinical history to know the duration of treatment that they're on. However, more than 25% of patients experience their first attack of angioedema more than 6 months after initiating an ACE inhibitor, and then some patients may have been on it for a year or two or more and still have an episode. Discontinuing the ACE inhibitor leads to resolution, but it may take up to 6 weeks or longer to completely stop all angioedema attacks. So patients who remain on an ACE inhibitor despite having an episode have a significantly higher risk. We're talking 50% or more with a recurrent attack in another year. So important statistics to know when you're talking about ACE inhibitor-induced angioedema. So one more point I want to mention is, what about the use of an ARB? Because this is going to come up, especially in your cardiovascular patients. What about the use of an ARB? They've done studies here showing that the cross-reactivity between those two is low. So what do you do in terms of management for that? I tell them that. I talk about the risk of development in that. It's not none, but it's low. I haven't quoted the statistics here in my talk. And then ultimately you have a discussion with cardiology about proceeding with ARB, because these are ultimately, therapies that can be very crucial to your cardiac patients. And it's not to say that ARB-induced angioedema has an incidence or prevalence of 0, but again, we need to weigh risks and benefits here of mortality of what's going to come, or morbidity that's going to come from what with those patients. Okay, treatment of acute urticaria, chronic urticaria, and mast cell-mediated angioedema. So here we have a trial dose of an FDA-approved second-generation H1 blocker as your first line of treatment. With just your FDA-approved dosing, 50% of patients will have resolution of their disease. Non-responders should increase the dose of the non-sedating antihistamine to up to 4 times the standard daily dose. That's going to be different depending on the age of the patients. You can add older generation antihistamines, you can add H2 blockers, you can add leukotriene receptor antagonists, but they are no longer the standard of care in acute urticaria, in urticaria and angioedema that's mast cell mediated. And so if you are in that situation where you have chronic urticaria with a non-responder, then you think about the addition of omalizumab, cyclosporin, however renal function needs to be monitored, and then dupilumab, recently gained an indication for chronic urticaria. In terms of treatments beyond biologic therapy and cyclosporin, what are other systemic treatments we can consider? So one important point, if you don't remember anything from today's talk except this one point, that's totally fine. Systemic steroids do not have a role in acute chronic urticaria, period. They don't have a role. So you're putting the patient at undue risk with your systemic steroids without additional benefits, especially when optimal therapies are readily available for their disease. So generally, systemic steroids, not recommended. What about doxepin? Doxepin is a pretty potent H1 blocker. It's a tricyclic antidepressant. It can cause a lot of sedation, especially in our pediatric patients. Doses of 75 milligrams per day or beyond require monitoring for arrhythmias. Hydroxychloroquine, Plaquenil, I would say is among the safety profile is pretty safe compared to some of these other ones. It can take 6 to 12 weeks to see an improvement. There can be a side effect of retinal toxicity, so you consider visits to an ophthalmologist while this has been done. I don't know why this point on COVID is here, so ignore that. Let's move on to Dapsone. Relatively safe medication, takes 6 to 12 weeks to see an improvement. Side effects here, so if there's a G6PD issue, you use caution or don't use this medication. It can cause G6PD-induced anemia, so CBC monitoring is recommended. And then you measure that level or consider measuring it before treatment. And then methotrexate. So this has been looked at. It's known to cause liver toxicity, so you need to monitor those levels. Basically, all of these treatments you may hear at some point in your allergy training for chronic urticaria, but the reality is that they have fallen out of favor in practice because of superior agents with a safer side effect profile. Okay, so in terms of what was studied for omalizumab in our trials here, it was compared to placebo at a dosing of 75, 300, and 600 milligrams with a change, of course, in the UAS7 as a parameter. And you can see that 300 milligrams had the biggest improvement here. As well as the biggest change here in your baseline UAS7 score. I'm going to talk about the role of 600 milligrams of omalizumab in just a little bit here. I'll circle back to that point. Okay, so because of that, the FDA-approved dosing of omalizumab is 150 or 300 milligrams every 4 weeks. However, off-label dosing of 300 milligrams every 2 weeks has been shown to be effective in non-responders, especially outside of the United States. This has been published to be effective. And so in individuals that fit the right parameters here, meaning they've had some or majority of disease response, but not full disease response, you can consider off-label dosing. And if that doesn't work, of course, you move on to other treatment lines. This is a subcutaneous injection. The major adverse effect here is reported to be anaphylaxis. You can consider having patients carry an epinephrine autoinjector. The first 2 to 3 doses are given in an in-office setting with a 2-hour observation for the first 2 doses. Dupilumab, the new kid on the block for chronic urticaria, has also shown significant reduction here in your urticaria activity in individuals who go on this for this particular disease. And you can see length of time of treatment results in a more significant reduction compared to placebo. In the right patient, some additional information here about dosing. So this is approved for children 12 years of age and above, and then adolescents less than 18 years of age. We have the pre-filled pen or syringe, and then here's the dosing that we find. And then adolescents or 18 years of age and above, you can use this particular dosing. Let's talk a little bit further about dupilumab. The decision between dupilumab and omalizumab can be difficult to make for this particular disease. I think assessment of comorbid atopic conditions is one parameter that you can use. But remember that dupilumab just recently gained an indication for this particular disease. There are other agents, including biologics, with more potent IgE binding that are in study. For chronic urticaria, there's also oral agents that are being studied for chronic urticaria. It can be difficult to know what agent to start off with. So discuss all of these treatments with whoever you're rotating with, and get a good understanding of ultimately how you would treat these patients going forward. Here are some pitfalls of urticaria and angioedema. Food panels and environmental panels. This question always comes up. What is the utility here? And the answer is that the utility is little to none. But what about the harm? Food panels can actually harm patients who have urticaria and angioedema, and that's the reason that they got it in the absence of the clinical history that is convincing for an IgE-mediated food allergy. So I've discussed this ad nauseum in the atopic dermatitis lecture and the food allergy lecture, but let's highlight it again in this talk. So the harms that can come include physical harms, loss of tolerance of the food, psychosocial harms, increased bullying at school, harms related to increased cost of allergen-free foods, harms including avoiding the less allergenic versions of foods. So lots of harm, and then increased costs as well. Costs now where you may have to carry an epinephrine auto-injector where you didn't need one before. And healthcare costs, now needing to see an allergist, now needing to undergo oral food challenges where you wouldn't have had to do that if you didn't get a food panel. Bottom line here, this is why food panels do not have a role in chronic urticaria or mast cell-mediated angioedema, again, where your clinical history is inconsistent with the food. Empiric elimination diet. So this has come up, it's been studied, what about, histamine-rich foods. Bottom line, multiple studies have reproduced this particular recommendation that empiric elimination diets are not recommended. Testing has a limited role in this disease, but this is the biggest point. If I can emphasize one other point from this talk, suboptimal management can lead to patient frustration, can lead to your patient coming back to the office over and over, can lead them to seek food panel testing outside of your office. So let's treat the patient to their goals is the bottom line. So acute management for angioedema, again, I apologize for how tiny the words are on this slide. For patients with hereditary angioedema, all of these agents are options here. We have C1 esterase inhibitor concentrate, we have recombinant concentrate, we have B2 receptor antagonists, we have kallikrein inhibitors, and plasma. All of these are for acute attacks. Availability is described here. Dosing is going to be weight dependent, and then precautions as well are all described here. And then long-term prophylaxis in patients who have hereditary angioedema. So the current agents that are approved include C1 esterase inhibitor concentrate, intravenous or subcutaneous lanadelumab, brilostat, androgens, and then antifibrinolytics. And then treat through for breakthrough symptoms can include icatibant and calantide. So all of these are listed here. The advantages between all of these are listed here. The disadvantages are also all listed here as well. And I know you'll have further talks on that, so I don't want to belabor that point too much. Let's talk about our summary here. Testing should be based on the clinical history. Are there features concerning for vasculitis or other systemic diseases? When we start with treatment for both acute and chronic urticaria, we start with the second generation H1 antihistamine, cetirizine, fexofenadine, possibly loratadine with levocetirizine. Usually at 2 to 4 times the normal FDA-approved dose is where you may need to escalate to in non-responders. Again, that's going to be 50% of your patients. H2 blockers and steroids are not effective. Don't use steroids. Refractory chronic urticaria can improve with omalizumab. So one other point here on cyclosporin. So although cyclosporin does have a risk of renal toxicity, it is very effective in controlling disease with chronic urticaria. You do have to monitor lab values. And one last point here, the dosing that we use is much lower compared to what, standard immunosuppression dosing is for cyclosporin. Last point here, please be sure to explain the nature of the disease to the family, reassure them about the nature of the disease, talk to them about the duration of their disease, thoroughly discuss treatment options right off the bat. I know it may seem unusual. Dr. Pandya, why are you talking about, biologic therapy when they've had chronic urticaria for like 8 weeks? Aren't you prematurely discussing it? Maybe. But also giving them an idea of what their treatment trajectory could be if they're a non-responder can help prevent seeking some of these unnecessary tests and treatments outside of, what you're trying to do for the patient. Here are my references.